Okay, let's start our first session. Dr. Bart de Vries from Belgium. Let's welcome him. Welcome in Cairo, Mr. de Vries. He is going to talk about what do we need for accurate diagnosis in case of abnormal uterine bleeding, hysteroscopy, ultrasound, or both. Please.
Yeah, thank you very much. It's a little late today, so let's just go on. Then afterwards we can have dinner. Yes. So I'm Bart de Vries from Belgium. So here you see my hospital. It's like only 1 year that is open. I'm very glad I'm in like a new hospital. And I also have like an endoscopic training center in Antwerp, Belgium. And I'm the medical director of the ISGE, International Society of Gynecological Endoscopy. So I'm going to talk to you about ultrasound. I'm a hysteroscopist, but still we use a lot of ultrasound. And in the diagnosis of abnormal uterine bleeding, we're going to see what we use the most, ultrasound or hysteroscopy. So first, okay, some introductory slides, then how to take a good endometrial biopsy. Then, of course, because we talk about ambulatory hysteroscopy or office hysteroscopy, we can talk about how to get the hysteroscopy out of the operation theater, and then some take-home messages. So what do we have what do we have to do what are our tools to do our assessment in case of abnormal uterine bleeding? If I talk about abnormal uterine bleeding, I specifically talk about the cavity and the endometrium. Of course, we always start with our transvaginal ultrasound and the Doppler. And then there are quite a lot of doctors and my friends of the University of Leuven, the very famous group of the IOTA group. They almost always do the ultrasound, the transvaginal ultrasound, and then they perform a gel infusion sonography to have like a good impression of the endometrium. I don't do it. I do transvaginal ultrasound, Doppler, and then I do an ambulatory or an office hysteroscopy, as I will tell you later. So these are the tools we use the most. And I like to show this slide. It's a slide from Dr. Van den Bos, and Dr. Van den Bos is from Belgium. He's like very famous because he is the leader of a group of ultrasonographers, and this is a very important paper because it's in fact, I call it the mother paper about how we should look at the endometrium when we are trying to diagnose abnormal uterine bleeding. Of course, there are a lot of other possible reasons to have abnormal uterine bleeding, but if we look at the endometrium, we see in this paper what the endometrium looks like in physiology. So it means proliferative secretory endometrium atrophy, and also in some abnormal situations. And you can read everything about it. So in this study, the IETA-1 is about almost 3,000 cases of abnormal uterine bleeding in the premenopausal and in the postmenopausal patient. And you can see the results here, but it ended in a really very nice description of how the endometrium in several physiologic and pathologic situations. So it is the 2D ultrasound and the Doppler features that are in this article. They did not just look in the 2D and Doppler, but they also did fluid installation, because when doing the fluid installation, the image gets more clear, and they they say they like more to use gel as a fluid, because the gel gives less reflux, less transtubal flow, and this is kind of important when you might have like malignancy. So less reflux, less transtubal flow for the gel infusion sonography. But as a hysteroscopist, why do I tell all that? Because for me, what is the most important if I see the patient with abnormal uterine bleeding is if we do the ultrasound, we check for the reassuring features. Because when we have a thin endometrium of 3 millimeter or less, or we have a really fine triple line, if we have like the midline that is really straight, and when we put the Doppler, we see inside the endometrium only one feeding vessel without any branching, this is really reassuring, and you can stop your investigation if you have these ones. Okay, now this was for the ultrasound, but in fact, I'm kind of a hysteroscopist. I think I'm born with a hysteroscope under my arm. So if I like to see things, I like to see it with my eyes, and I like to take biopsy, so that for me, this is, I feel more comfortable with it. So I'm a little bit like Linda Bradley say, my hysteroscope is my stethoscope. I need to see it with my eyes. And this is how my setup is in the consultation when the people are referred for abnormal uterine bleeding. So we have like the ultrasound on the left side. I do what Dr. Van den Bos and IETA have asked us to do, but immediately afterwards, I do a diagnostic hysteroscopy, office hysteroscopy. And in fact, this tower is my tower from the operation room. I take it down 3 times a week in the consultation room. And after doing the hysteroscopy, I immediately redo the ultrasound. There is still the fluid inside, so we have like the saline infusion. This is my setup for the diagnostic setup. Okay, so when we look at the endometrium, and I go fast, of course we look at the thickness of the endometrium. We look at the surface, because sometimes you have irregularities, you have edema, you have polyps, you have like micropolyposis, or you have like crypts, like you have in adenomyosis. We look at the color of the endometrium, because we can have like this purple-like adenomyosis, superficial adenomyosis, or you can have like this strawberry pattern, but I will tell you later that we kind of like to call it IISE, so I will tell you later what it is. We look at the vascularization. We can have like the abnormal vascularization, like in atypia or in carcinoma. And in fact, I'm not going to tell you too much about it, but everything is described in the papers and in different atlas, going from physiology to pathology. But if we look at the endometrium, there is one person I wanna talk about, and that is Dr. Amal Drizzi, who has given us another view on the strawberry pattern. If you see the strawberry pattern, everybody says this is endometritis. Well, Dr. Amal Drizzi asks us not to talk about endometritis anymore, but to call it inflammation, a sort of inflammatory state of the endometrium, because it's only in a very tiny piece that there is actually a bacterial endometritis. So the new name she puts on this pathophysiological situation is IISE, which is impaired inflammatory state of the endometrium. In fact, it means that we have like hypervascularity, we have like hypertrophy of the stroma, we have edema, and not over all the cavity, but sometimes it's only in certain parts of the cavity. So she invites us to, when we see it, to take a biopsy and to think about this situation and not always give antibiotics, and think about and to see the whole patient and think why there is this inflammation. Because there are a lot of possibilities, like obesity, like hyperthyroidism, like other metabolic and endocrine situations like allergy. So it is a very nice idea, and think about it. And let's not talk about endometritis anymore, but about inflammatory state of the endometrium. How do we take the biopsy? I will just go through with you. So we use the grasp technique and not the punch technique anymore. I will just show you a little video how I take the biopsy. Probably you know already. So we are in the consultation room. We go with the Betoki inside. So this is like an area where I think, well, is this inflammation? We put our grasping forceps and we go forward for 2 centimeters. So to grab a larger piece than we just would do a punch biopsy. This is how we do the biopsy. And I'm going to skip this one because it is really proven in big series that, in fact, if you take 1 or 2 eye-directed biopsies, you have the same or even better results of diagnosing hyperplasia, atypia, and carcinoma. Of course, you have seen me doing office hysteroscopy, and I would like to tell you, you have to try to do office hysteroscopy, because now most of you do the hysteroscopy sometimes under anesthesia, under maybe local anesthesia, but take it out of the operation room, take it to the consultation room. You have seen it's not such a big setup, but you need, of course, the small instruments, Betoki, Trophy, others. You need to learn the vaginoscopy. You need to maybe arrange your treatment room that the patient is not so has not so much fear, that the anxiety is rather low, and you need 1 or 2 nurses that work always with you that calm down the patient, and then everything comes all right. And just for the future, there are some new equipment coming. I don't use it at the moment. Yes, I use the Bugatti shaver in the operation room, but now they make the Bugatti shaver, not the big one, not the medium one, but you have like a very tiny shaver now. It is on the market. I don't have it yet, but while the shaving will be possible with the very tiny one, it could be possible to also take larger biopsies, taking polyps and everything also in the outpatient. So this is just a photo of the really small Bugatti shaver. You see the normal tissue removal system of Bugatti. This is the system that we use in the 24 and 19 French, and you see they have like a tiny one that we can use in the outpatient. And I will just show you what is possible maybe in the near future. When we look at this polyploid endometrium, it's really rather difficult to say where to take the biopsy, but with these new shavers, it would be possible, as you see here, to introduce the shaver, possibly in the outpatient or in the office, and then this is the big difference with the small resectoscopes, that you can actually shave this endometrium, this polyploid endometrium, and the suction will will take all the tissue inside your little tissue bag, and you can actually take all the cavity, and this would be ideal, I think, for the lots of patients with obesity and with the polyploid endometrium in a diagnostic and probably also therapeutic fashion. Okay, so to end my presentation, I think both diagnostic techniques, ultrasound and hysteroscopy, in experienced hands are in many areas equal in the diagnostic, in diagnosis of abnormal uterine bleeding. But hysteroscopy, of course, has the opportunity to take eye-directed biopsies. Hysteroscopic eye-directed biopsies, the accuracy scores better than blind endometrial sampling alone. And more centers are moving from a 100% diagnostic setting to a setting with treatment possibilities because of newer equipment. Thank you very much.
Thank you very much, Dr. Bart, for this interesting presentation. It's really nice. Professor Omar Shaban has a couple of questions, please.
Thank you, Professor Perth, for this interesting presentation. It's just a reflection on the video I presented about the possible inflammation of the endometrium. I had a study about 7 to 8 years ago about bleeding with progesterone-only contraceptives. And I was performing hysteroscopy for those bleeders. And we had hysteroscopic guided biopsies from these ladies, from these patches of hyperinflamed areas, and analyzed by immunohistochemistry or immunohistopathology. And the end of the day, it shows that these pictures come from hypervascularity of the endometrium on the expense of the stroma. So it's a kind of aseptic inflammation that caused by these progesterone-only contraceptives. I don't know if you are still using what we call it Hopkins 2 lens for microhysteroscopy. It's a lens with a magnifier that is still valid, or is it still used for detecting the site of the biopsy?
I think we don't use it anymore, the Hopkins one, like before. But still now, you can still go with your hysteroscope against the endometrium and evaluate the superficial vessels and the deeper vessels. But I think if you want to take your biopsies, you can take it also in the visual field you have before you. I don't think you have to go in contact. There are some papers now about contact hysteroscopy, but they are all in experimental phases. It's not that I can give you a concrete advice for that. But you are absolutely true that it is inflammation. So most of the time we have to think otherwise than give antibiotics. We have to stop the treatment and try to have these ladies to have like a normal cycle. Probably they will heal. And so we have to think in another way about this strawberry pattern.
Thank you, sir, for this precious talk. I have a simple question. If there is a case of endometrial cancer and you are going to diagnose it by hysteroscopy and biopsy, isn't there a chance of spreading the disease in the pelvis during hysteroscopy?
There is two answers. One, normally we do hysteroscopy with a pump. And if for diagnosis, we put the pump really low. Low means below 70 millimeters mercury. And we know that at these low levels, there is no tubal, there is no nothing going to the abdominal cavity. But of course, sometimes we don't use the pump. We put higher pressures, or we have the pressure bag, and we know there are cells going into the abdominal cavity. What we also know, and it's acknowledged by the FIGO so many years after years, that even in an endometrial carcinoma, and if we by hysteroscopy have some cells in the abdominal cavity, there is no reason to upgrade the TNM score. So the grade of the endometrial carcinoma is not upgraded by having these cells inside the abdominal cavity. That is the clinical relevance of doing all this testing of malignant cells in the abdominal cavity.
So, in spite of being safer to take it blindly, you prefer to do it by hysteroscopy for better accuracy of diagnosis, right?
There are a lot of papers that say that if you do it by hysteroscopy, you will find a higher number of endometrial carcinomas, and sometimes the PIPEL is negative. So this is what we have to balance.
Thank you, sir. Our next talk, titled PCOS is Enduring Lifelong by Professor Dr. Muhammad Imam.
بسم الله الرحمن الرحيم. يعني اولا انا بشكر الدكتور حاتم الجمل and the organizing committee for inviting me for this talk. My talk is polycystic ovarian syndrome is enduring lifelong. We know that the polycystic ovarian syndrome is a multifactorial endocrinopathy resulting from interaction of 6 factors. The main factor is genetic and epigenetic, and we know that the epigenetic include many items like metabolic, which is the central player, neuroendocrine alteration, like epilepsy, environmental factor, which include endocrinal disruptors, which are pervasive in our community, and now dysbiosis of the gut, microbiota, dogmata. So that this epigenetic can interact with the genes and result in polycystic ovarian syndrome. This is the central player for the condition. The background of my talk is the polycystic ovarian syndrome prevalence from 10 to 13%, and this syndrome is enduring lifelong. The say إلى الأبد موجود طالما بدأ مش هينتهي in Arabic. Present during different stages of life, which include adolescence, reproductive age, and menopause. So my objective to raise the awareness about the diagnostic criteria of this syndrome during different stages of life. Not only as the reproductive age group like Rotterdam criteria, which are very important for us, and we forget the adolescents and forget the post-menopause and the other age group. The source of evidence of my talk, many items, international evidence-based guidelines for the assessment of management of this syndrome, 2018 and 2023, and the American Academy of Pediatrics 2020, Ishri Asram, and the ASOGIC 27, systemic review and meta-analysis till January 2024. The stages of life we know that include infancy, toddler, and infancy it is the neonate to 1 year, and the toddler 1 to 3 years, childhood from 3 to 11 years. You should know this age, and adolescents from 11 to 20 years, and so from menarche till 20 years, till 10 years. Adulthood from 18 years to menopause and the post-menopause. This is the stages of life of all of us. The risky infant children for polycystic ovarian syndrome, you should know that infant and children are very risky to occurrence of polycystic syndrome among the following categories: childhood obesity, and when you see childhood epilepsy and premature puberty, that say the pubic hair arise about 10 years old, and the family history of the syndrome, diabetes, alopecia, maternal obesity during pregnancy. If the mother has a maternal obesity during pregnancy, you should suspect that this infant will grow and will be at polycystic syndrome and adolescence. And the polycystic syndrome and adolescence, this area age of life presents during adolescence of this syndrome within 8 years from monarch. Now the WHO classification of the age of adolescence 8 years after menarche. So you should be alert about this age, but not always diagnosed at that age. Why? Yeah, at this age, no diagnosis, many cases will be missed because the features of normal adolescence development overlap with the diagnostic criteria of this syndrome among this age. Though the adolescent polycystic syndrome can be diagnosed by the following: hyperandrogenism and irregular menstruation. Orthodontic criteria for adulthood include 2 of these 3 items, but in adolescents, only 2 items. They say hyperandrogenism, which is a clinical picture of hyperandrogenemia, and irregular menstruation. Polycystic ovarian morphology, that say not needed at that age. Why? Because at this age, many polyfollicular ovary can be mimic or can mimic this polycystic ovarian morphology. The adolescents, the growth of adolescent polycystic ovarian syndrome, when hyperandrogenism, clinical or biochemical. I stress here on clinical or biochemical, and irregular cycle, post-menarche, and also I stress again that the polycystic morphology not essential like adult. Why polycystic morphology is not essential? Due to the high incidence of multifollicular ovaries in this life stage. That lead to false increase in the prevalence. What is the multifollicular ovary? Multifollicular ovary is occurrence of ovary filled by follicle more than 9 millimeter. But the polycystic ovarian morphology occurs when the follicle from 2 to 9 millimeter only. If the follicle more than 9, it is not polycystic ovarian morphology. So the clinical hyperandrogenism, you can continuous and the clinical hyperandrogenism about 80% in the adolescents. This occurs in severe acne and hirsutism. If you face a case with severe acne or hirsutism, you can diagnose that the case is hyperandrogenism. But it is mild, it is called biochemical hyperandrogenism, which need other investigation, which this indication need high quality assay is the method of choice. اللي هي التحليلات اللي عندنا في الماركت not diagnostic or pathognomic of hyperandrogenism, but high quality assay which is not present in our lab, in many labs in Egypt. And you should diagnose free androgen index by the total testosterone upon 6 hormone binding globulin multiplied by 100. It is normal from 7 to 8 or to 10. This is the picture of loss of hair and hirsutism, and we all will know. And the irregular menstrual cycle in this age, the first year post-menarche, it is very normal. You say not depend about it for the first year, but from 1 to 3 years post-menarche, the cycle length is from 21 to 30 up to 45. After 3 years, from 21 to 35. You should know that the adolescent at this, what is the age of adolescent after menarche. If 3 years, they say it is a range from 21 to 35. Primary amenorrhea now can be diagnosed by if the absence of menstruation 15 years or 3 years post-menarche or post-breast budding. So this is a new classification of the irregular menstruation in adolescent, and you should know these items. Also, the adolescent with one diagnostic feature, which is irregular menstruation of hyperandrogenism, it is high risk for occurrence of polycystic ovarian syndrome at that age, or any of this criteria, hyperandrogenism plus metabolic syndrome, can lead to after that for polycystic ovarian syndrome after this age. Now, the number 3, the reproductive age group, we all know that it is the Rotterdam criteria, which is very famous to us, hyperandrogenism and oligohypomenorrhea or polycystic ovarian morphology. 2 of these 3 items can diagnose the syndrome. So, now, recently, 2023, anti-male hormone more than 3.4 nanogram per milli is considered as a strong predictor of polycystic ovarian morphology among the reproductive age group, not diagnostic for adolescent. So you can replace the ultrasonic criteria for polycystic ovarian morphology by anti-male hormone at that age, adult. If more than 3.4, it is the pathognomonic for polycystic ovarian morphology and can replace the ultrasonic criteria. Now, what is the diagnosis of postmenopausal polycystic ovarian syndrome, which you should know? It is a missed topic and it is forgotten for us. It is a persistence of hyperandrogenism, clinical or biochemical, in postmenopause with past history of hyperandrogenic polycystic ovarian syndrome phenotype. If a case has a polycystic ovarian syndrome hyperandrogenic and enters the menopause, that say with hyperandrogenism, it is polycystic ovarian syndrome in this age. So the diagnosis of polycystic ovarian syndrome postmenopausal, it is include only what is resistance of hyperandrogenism and the absence of polycystic ovarian morphology or irregular menstruation. It is absent menstruation now. You can depend on this item only if this case has the syndrome in her adult life. Now, what is the postmenopausal hyperandrogenism generally? We know that it is include 9 tumorous factors, and the tumorous factors which are androgen producing neoplasm, ovarian and adrenal. But I stress here on the first 2 items, which is polycystic ovarian syndrome and hyperpsychosis, which are missed to us. Other causes like hyperprolactinemia, hyperthyroidism, ingestion of anabolic, and congenital adrenal hyperplasia are very essential for us. But you should not miss the first item, which is polycystic ovarian syndrome among the postmenopausal, which it is again extension of the hyperandrogenism from productive life till after menopause in this case. So, what is the difference? How can differentiate between these 3 items or all items? You should investigate by testosterone level. If the testosterone less than 150 nanogram per milli, it is a polycystic ovarian syndrome. But it is from 150 to 20, it is hyperpsychosis. Hyperpsychosis is a severe form of polycystic ovarian syndrome among this age. After that, if the testosterone more than 200, you should know ultrasonic and MRI or CT for the ovary and the adrenal tumor. And you should do DHEAS more than 700 nanogram per milli. It is adrenal hyperplasia or tumor. So you can need testosterone level and DHEAS for some cases. Now, what is the interactions of this syndrome and the menopause? Polycystic syndrome not vanish away with menopause. Yani you should know that after menopause, the syndrome not vanish as we have said. Some of the symptoms of the perimenopause and menopause and the menopause overlap with the syndrome. And the hot flashes not worse in the syndrome after menopause. Increased late or delayed menopause. You can confront it with a case of postmenopause after 3 or 4 years more than we know. That says that the mean age of menopause about 51. Some females extend the age of menopause to 55 or 54. You should suspect here that she has a polycystic ovarian syndrome. And there is augmented specific consequence after that. These cases are liable for many consequences which are very essential and very dangerous, like cardiovascular disease, endometrial cancer, and also metabolic, non-insulin diabetes diabetes, and sleep apnea and psychiatric disease among this age group. You should be alert about these cases in that age. My conclusion, Mr. Chairman and their colleague, polycystic ovarian syndrome is enduring lifelong, which must be managed throughout the woman's life. Polycystic ovarian syndrome changes during the different stages of life, from adolescence, reproductive age, and menopause. Each stage requires a personalized diagnostic approach and treatment. And with increasing age, the syndrome evolves from reproductive problem to metabolic disorder. كل تركيزنا ان العيانه بتاع this syndrome has infertility and the other reproductive age. But after that, the metabolic disorder are very frequent. The syndrome presents during adolescence in risk children, with stress hair in risk children, but not always diagnosed at that age. And be alert for the picking and following up at risk children, which are obese child, which has epilepsy, premature biobark, and with family history of the syndrome, diabetes, alopecia, or maternal obesity during pregnancy. The future, we hope that the enduring lifelong of polycystic ovarian syndrome be one-day history by modulation of its genetic expression through prevention of the interactions of the genes and the epigenetic factor. ودي الامل بتاعنا فيما بعد علاج السندروم. السندروم لا يعالج ولكن it is enduring lifelong. بس الامل اللي هو تغيير الموديوليشن بتاع الاكشن بتاع الجينيتيك اند الايبيجينيتيك. Thank you very much.
Thank you, Professor Imam, for this great presentation. I think the time can allow one question if there is any. Dr. Salama.
الادolescence is 8 years after menarche. دي الفترة ديت هي فترة الادolescence. menarche occurred about 11 years, so at 8 years within this period, it is called the adolescence. So you can diagnose any female with the age 8 years after 11 with criteria of irregular menstruation and hyperalgeism. You should diagnose polycystic ovarian syndrome without need for ultrasonic and diagnose polycystic ovarian morphology among this age, because the prevalence of what is called polyfollicular morphology, which is a presence of follicle more than 9 millimeters. Thank you very much.
Thank you, Professor Imam. And may we move to the next presentation titled Professional Awareness Saves a Lot by Professor Ali Samman. He's a professor of obstetrics and gynecology in Asyut University. And he's one of the pioneers in the endoscopic surgery. I think today he will going to present a general topic for all audience. Thank you. تفضل دكتور علي.
Thank you, Mr. Chairman, and I would like to congratulate and thank the organizing committee for this world-class conference. Bismillah ar-Rahman ar-Rahim. Professional awareness saves a lot. الوعي المهني ولازم نعرف ان هو مش مقصور على الطب فحسب، هو can include any profession. لكن عموما انا هتكلم على consequences of the most annoying for medical errors. About this, I talk about the captive genital system, the misdiagnosis of genital conditions with shouting diagnostic clues, the hard decisions for ending potential lives, and the inability to adopt valuable developments. دي سلايد بتقول ان البروفيشنال اويرنس ما هياش بس ليميتد للميديسن، في اي فيلد، في الاجريكلتشر، في اللعب، في الصحافه. يعني لو بصينا على النعي بتاع الفيجو لاستاذنا بروفيسور فتح الله، فيجو is deeply saddened to hear about the death of Professor Mahmoud Fathallah, his magnanimous presence will be profoundly missed. كلمات رغم قلتها لكن بتعني الكثير والكثير. كلمات فعلا تختلف تماما عن نعي واحد من أعلام الطب في أسيوط، بروفيسور مراد، اللي لما مجلة كتبت عنه لفظ الدكتور فاروق أحمد مراد الشهير بفاروق، لا حول ولا قوة إلا بالله، يعني one of the figures of surgery in Upper Egypt, in Egypt. واحد يعني من اللي تعدوا على الأصابع في الشغل بتاعه في كل شيء، ينعى بهذه الكلمات الخفيفة التي لا تعبر عن شيء. إذن professionalism is the ability to conduct a given job in the best, safest, fastest and satisfying quality that characterize a profession or a professional person. هنتكلم على الميسنج جينيتال أو الإيرورز of annoying errors of lack of professional awareness. This is a captive genital system. بعد single cesarean section نبص نلاقي الأوفريز اتلزقوا في اللاترال pelvic wall، واليوترس اتلزق في الانتيرو abdominal wall، وبجريدز مختلفة بنشوف فيها difficulties in subsequent surgeries, difficulties in the reproductive performance after these annoying problems after a single, mostly unindicated cesarean section. This is annoying professional deficits, and the problem is not to correct this. The problem is how to prevent this, and preventing this is a great need in nowadays in order to dry the channels of unnecessarily minimally invasive or maximally invasive surgeries. The misdiagnosis, this is the first part, the captive genital system, and it is a frequent complication of unindicated, unprofessionally performed cesarean section. Missing the genital conditions with shouting diagnostic clues, like this newborn with abdominal distension that may amount to renal failure for this neonate because of a genital condition. This problem is not solved by pediatric surgeons, by pediatric exploration with the abdominal cavity. It is solved by pull-down balloon vaginoplasty. Such baby will suffer if treated classically, but if we are professionally aware and we put in mind that this neonate with this annoying problems, these life-threatening problems that may amount to renal failure, which is known as Makusi-Kaufman syndrome. Makusi-Kaufman syndrome is a life-threatening, fertility-threatening, easy diagnosable and effectively treatable gynecologic problem. بتتحل بمشكلة بإن احنا نعملها pull down balloon vaginoplasty. The shouting diagnostic clue for all patients or neonates, adolescent with Makusi-Kaufman syndrome is the presence of polydactyly in all limbs. So she has a shouting diagnostic clue. In spite of this, many miss the diagnosis and explore such cases and may result in ending their reproductive potentials. Shouting symptoms. Young females with progressive dysmenorrhea, like الجميلة نجوان وصرخات تهز الكيان. عندها ايه؟ عندها obstructive Mullerian anomaly or obstructive menstrual anomaly. وتبقى misdiagnosed على انها appendicitis, then peritonitis, then many explorations that loses this patient her fertility, loses her potential future for reproductive performance. For those, we say any adolescent female with progressive cyclic pains or progressive dysmenorrhea should be considered as obstructive Mullerian anomaly until proved otherwise. Otherwise, she will have debilitating disfigurement of their soft, beautiful skin. In Asyut University, we are moving from misdiagnosis and mismanagement to innovative thoughts, like this simple tool that made from a pediatric Foley's catheter in order to a pediatric silicone catheter in order to treat distal vaginal atresia as a T-shaped self-retaining stent for solving this problem. The hard decisions for ending potential lives is one of the consequences of the most annoying for medical errors. An example for this is the niche pregnancy and cesarean scar pregnancy. Most of cases of placenta previa, placenta accreta, were cesarean scar pregnancy. How many babies are born nowadays from placenta accreta? They all were cesarean scar or niche-related pregnancy. So the hard decision for terminating pulsating fetus with this condition is ending potential life. So expectant management should be the first line after meticulous counseling, after careful evaluation, and after careful attention to the possibilities of mid-trimester rupture uterus and mid-trimester bleeding. Another problem, and this for all people who work in the field of hysteroscopy, because of the possibility of air embolism. Air embolism is a potential fatal condition. It is a cause of losing potential lives. Whenever you are working in a hysteroscopic theater and you see collapse of the patient, the anesthetist became disturbed, loss of saturation or decreased saturation, or the presence of sudden hypotension, this should arise the attention that this is an air embolism. If the management of this problem is not in the mind of the hysteroscopist, you will lose this potential life. نعمل إيه? You should shout. You should extract your instrument whatever may be the stage of operation. لو حتى باقي حته صغيره في المايوم ما تقولش خلاص قربنا، لا، اطلع بالآلات بتاعتك as soon as possible. Once ان البيشنت كولابست في الهيستروسكوبي almost ما فيش حاجه تخليها تبقى كولابست except air embolism. The next thing, shout for all people in the theater, put the patient head down, put the patient in Trendelenburg position. Shout them again, put her in the left lateral position. If there is a large air bolus in the right ventricle, this will be moved to the apex of the heart and the blood pressure will regained and the saturation will be better after this shouting for saving these potential lives. The last medical error is the inability to adopt or failure to adopt valuable developments. This was a case returning back from London. She is a Kuwaitian lady. كان عندها absent vagina. دكتور مصري هناك قال لها هتروحي مصر تعملي عملية بتتعامل في مصر، عملية سو ساتسفاينج اسمها بالون فاجينوبلاستي. الست قالت له، وهي اللي بتحكي ما حدش تاني حكى غيرها، مصر لأ. الحكومة الكويتية عملت لها ورقها وسافرت لندن. هناك عرضوا عليها العمليات اللي بتتعمل، باول فاجينوبلاستي، فلاف فاجينوبلاستي، partial thickness operation. All of this were very annoying for her. She got depressed and she go back to her country. There she met the Egyptian doctor again. She convinced to came to Egypt. We performed for her balloon vaginoplasty, an Egyptian operation. From the year 2003 till the moment, we treated hundreds of cases, 800 almost, and she was so satisfied with the outcome. The new vagina developed by balloon vaginoplasty adapts the adult size cascospiculum and its covering is stained with iodine. No scars, no donor scars, no donor site scars, no hair inside the vagina. This case قالت هذه الكلمات رغم سعادتي وانبهاري، إلا إنه حرام عليكم، ليش في لندن ما يتعرفوش على العمليات السحر اللي بتعملوها في مصر؟ مش عارف نقول إيه بقى في الحالة دي. قلنا إحنا عملنا الشغل بتاعنا، نشرناه في الانترناشونال جورنال سنه 2007 واوردد الفيجو برايز as being the best research article for solving this problem. عملنا الموديفيكيشن فيها ريتروبيوبيك بالون فاجينوبلاستي وبابلشد في الفيرتيليتي اند ستيريليتي. عملنا موديفايد بالون فاجينوبلاستي عشان تتعامل بالكونفنشنال انسترومنتس وبابلشد في الامريكان جورنالز. عملنا بورت ساين موديفيكيشنز وعملنا لابرو اندوسكوبيك سايت سنجل سايت بالون فاجينوبلاستي وبابلشد في الاوروبيان جورنالز. وعملنا ترانس امبيليكال فاجينوبلاستي ثرو فراكشنيتد بورتس. الاوبريشنز بابلشد في الجرين جورنالز واتحطت على الكفر بيج بتاعتها. واتعملت الاوت بيشنت بالون فاجينوبلاستي وبابلشد في الامريكان جورنالز وفي الاوروبيان فيلد وفي الفيرتيليتي اند ستيريليتي. وان a group of operations حتى لما تفرقع البالون، وكان اول واحد تنبأ بيها والد الاستاذ الدكتور عمر شعبان، استاذنا الدكتور ممدوح شعبان، وقال هتفرقع وما فرقعتش غير في الحاله رقم 56، وكانت جايه حاله جايه من كندا عشان تعمل بالون فاجينوبلاستي وفرقعت فيها البالون. وقدمنا ريسكيو مانجمنت بلان فور بيرست بالون، وقدمنا انذر ميثود فور مانجمنت اوف بيرست بالون، وعملنا انفيرتد بالون فاجينوبلاستي وبابلشد في الامريكان جورنالز. عملنا دول فورس بالون فاجينوبلاستي في الحالات اللي فيها upper vaginal pouch. A group of operations published. نشرنا السكسسفul pregnancy outcomes after our surgeries في الحالات اللي فيها functioning uterus. العمليات اتحطت على الكفر بيج بتاعت الفيرتيليتي اند sterility. endoscopically monitored the canalization of the vaginal atresia. transmyometrial hysteroscopy. اعتقد ان دي Egyptian innovation. في حد عندكم بيعمل transmyometrial hysteroscopy وpublished. We reported successful pregnancy outcomes after transmyometrial hysteroscopy. وعملنا الحالات السيرفايكال اتريزيا stents وريبورتد positive reproductive outcomes سواء على مستوى المينسترال outcomes او مستوى السكسسفul pregnancy outcomes after stents وهكذا. قدمنا كل ده ومع هذا في failure to adopt. وكنا أول من يتكلم عن الهايبريد سبتيت يوترس with a fundal depression. وأول 2 international publications طلعوا من أسيوط من إيجيبت. ولما اتكلمنا عن الكلام دوت استاذ الدكتور ممدوح قال علي صوتك وعيد تاني لما قلت ما فيش مكنه بتطلع سبتيت ومكنه بتطلع بايكورنويت. وده طبعا كان تنبؤ بان العمليه دي، رغم ان انا قلت الكلام ده وانا نائب في قسم امراض النساء، كان تنبؤ بان ده هيكون اول اكتشاف للهايبريد سبتيت او الهايبريد بايكورنويت على مستوى العالم هيكون طالع من مصر. ومع هذا ومع كل هذا وتقديم الباك اب ميثودز اللي هي بابلشد في الفيرتيليتي اند ستيريليتي، في اجنورانس لهذا البروجريس وفيلير تو ادوبت. وفي واحده من اعظم جامعات مصر بيتعامل المجهود الجبار دوت، والناس كانوا امنا بشكل خلوهم يعرضوا الكومبليكيشنز اللي بتحصل بعد العمليات الكلاسيك فور فاجينوبلاستي، وبنقدم البديل، ولكن ليس هناك من يسمع لا في الداخل ولا في الخارج. دي مشكله احنا بنعاني منها، انه في failure of adoption of innovative thoughts اللي بتجنب البيشنت ان يحصل لها فيستولا زي كده بعد بالون بعد كلاسيك فاجينوبلاستي، وبتجنبها اللوس اوف بيوتي، وبتجنبها مشاكل كثيره جدا جدا ممكن لو احنا عملنا ادوبشن للانوفيتيف تكنيكس، حتى لو كانت جايه من بلد من دول العالم الثالث زي ما بيسموه، كان يخفف من معاناه الكثير. بشكر لحضراتكم حسن استماعكم. يبقى
Thank you very much for your nice presentation, Professor. All of us like Egypt, like you, of course. Now, with the next presentation with chronic endometritis and infertility, Professor Dr. Mohammed Salam.
First of all, I would like to thank the organizing committee, especially my dear Professor Hatim Al-Gamal, and congratulations for this fruitful, successful meeting. Chronic endometritis and infertility. The outline of my talk will include definition, predisposing factor, etiology, clinical signs, diagnosis, treatment, and management. As the professor said in the first lecture, endometritis is an inflammation, persistent inflammation of the endometrium that is characterized by the presence of plasma cell. On the same time, there is an abnormal uterine chronic endometritis, that's to say, activated immune response and induced abnormal cell proliferation. So, endometritis is a condition involving the breakdown of peaceful coexistence between the microorganism and the host immune system in the endometrium. What are the causes? Chronic inflammation of the endometrium may follow peripheral sepsis and or cesarean section, but in a procedure done through the cervix may predispose to chronic endometritis like D&C, endometrial biopsy, even hysteroscopy, and the placement of IUCD. What is the pathophysiology? It is a triad in the form of alteration of the endometrial receptivity, out of phase of endometrial morphology, and uterine contraction pattern change. Regarding the altered endometrial receptivity, there will be a progressive high level of estrogen and progesterone receptor. On the same time, plasma cell and the immunoglobulin involved in the inflammatory reaction exert a negative influence on the endometrial receptivity. Out of phase of the endometrial morphology is also present or criterion, and altered peristalsis of the uterus endometrium is present. What are the clinical picture? There may be nothing, there may be pelvic discomfort, abnormal uterine bleeding, leukorrhea, but as regarding to the fertility of the patient, there may be implantation failure and recurrent of miscarriage, and the incidence of each of these clinical signs illustrated in this table. As regard to the diagnosis, it may be an ultrasound, conventional tissue staining, immunohistochemical diagnosis or staining, microbial culture, hysteroscopy, and the newer diagnostic tools or methods. The ultrasound criteria is not characteristic, but the persistent endometrial focal thickening or echogenicity is present. On the same time, persistent thin hypovascular endometrium with altered junctional zone in pre-ovulatory as well as the secretory phase. The conventional tissue staining is very nice using the basic hematoxylin and eosine staining, and there will be multiple endometrial stromal blastocysts. But if we are going to take a biopsy, it is more better to be from the lateral uterine wall or just above the cervical canal. But nowadays, immunohistochemical staining for plasma cell called Syndican-1 is considered as the basic diagnosis or the gold standard in the diagnosis of chronic endometritis, and the histopathology of such a case will be by plasma cell highlighted by Syndican-3 staining in the center of this picture. More detailed picture of the plasma Syndican immune will be in figure 1. Microbial culture of chronic endometritis also may reveal streptococcal infection or chlamydia infection. IVF expertise tip to say, don't miss the role of hysteroscopy in diagnosis of chronic inflammation of the endometrium. That is to say, presence of local of diffuse hyperemia, edematous stroma, presence of micropolyps, small pedunculated vascularized protrusion of the uterine mucosa measuring less than 1 millimeter in size. But the clue for diagnosis of colonic endometritis during hysteroscopy will include endometrial surface is completely covered by micropolyp, isolated micropolyp on the lateral wall of the cavity. Endometrial mucosa appears to be thick, edematous, diffuse, hyperemic, with the presence of micropolyp, and there will be a clinical intraoperative test that is to touch the endometrium by the edematous hyperemic endometrium by the tip of hysteroscope, and there will be a small bleeding. On the same time, there is a detailed image of endometrial micropolyp appearance seen in D. What are the newer diagnostic methods? PCR, as we know, is a good and diagnostic test. It is of low cost, less time consuming, identify and quantify very small amount of bacterial DNA, irrespective of the culturable or non-culturable nature. Microbiome results using next generation of sequencing, NGS. And nowadays it is easy, and we'll evaluate its value in the coming slide. Endometrial sample will be taken for DNA extraction, RT, PCR analysis, then report, then prescribe the treatment. The treatment modality indicated with unexplained infertility or recurrent pregnancy loss and recurrent implantation failure. The ideal, as we know, is to use the targeted antimicrobial therapy. However, empirical antimicrobial therapy may be used in the form of doxycycline, and it is the preferred treatment using 200 milligrams per day for 14 days, and there will be a clearance of the plasma cell in about 70% after therapy. Combination of ciprofloxacin and metronidazole in resistant cases for doxycycline. Chronic endometritis, and these are the papers confirming these results. Endometrial scratching may be an option. The proposed mechanism is topical injury lead to desodularization of the endometrium, release of cytokines and growth hormone, and delays area maturation. However, hysteroscopy in chronic endometritis option is beneficial also. Why? The mechanism proposed is physically removing the bacterial biofilm and clear adhesion and polypi. There is a specific type of chronic inflammation, that's to say tuberculous endometritis. It is more common in India, in most of the region of India, and it was diagnosed in about 50% of infertile cases with extragenital tuberculosis. Also, it is present here in Upper Egypt, and our lead professor Hussam Sabit has many papers and publication about this. The treatment, it is management of genital TB, that is to use the therapy for not less than 6 months to 1 year, and confirm the treatment, the success by hysteroscopy or biopsy. Why biopsy? It is better. Tissue is the issue, And in such suspected cases, the best site to take the biopsy is around, at the end of secretory phase, just above the cervical canal. A newcomer is the reproductive microbiome. Microbiome nowadays are called the second human genome, and endometrial dysbiosis is a proposed etiologic factor for chronic inflammation of the endometrium. And the SWOT analysis was done. There was strengths for such inclination of the microbiome and the weakness area. Mr. Chairman, my dear audience, chronic endometritis is a manifestation of asymptomatic pelvic pain, abnormal uterine bleeding, leukorrhea, and the risk factor for infertility, recurrent implantation failure, and intrauterine adhesion. The histopathologic diagnosis is a proof. Hysteroscopy has a role. Pathogenic diagnosis is a confirmatory one. Going to the cost analysis of the newcomer NGS. As we know, BGS 40 is a one method, laser hatching is a second, ERA-test is another option, but treatment of chronic endometritis is nowadays it is available, more cheaper, with no extra cost. In conclusion, associated chronic inflammation with unexplained infertility, repeated reproductive failure, and recurrent miscarriage was proved should roll out before offering more expensive option of treatment in recurrent implantation failure. Multiple diagnostic modalities are nowadays available. Diagnosis and the treatment of chronic inflammation of the endometrium with suitable antibiotic may result in an increase of spontaneous conception and reduction in miscarriage. Overdiagnosis and the treatment must be avoided. Detailed understanding of the dynamics of uterine microbiome and the implication of its imbalance is present. The role of probiotic infertility treatment needs to be established. In إشري الشعار بيقول science is moving, people moving science. Thank you very much for your attention.
Thank you very much, Dr. Muhammad Salam, for this interesting topic. Now the next speaker is Professor Ala Badawi. He will present polycystic ovary and body mass index.
Thanks very much for your introduction, and thanks for the honorable community and the honorable society of this Congress for letting me, as a general surgeon, to present a case, some cases for this topic. As you all know, factors affecting obesity factors affecting obesity are generally, we all know, is eating habits, reduced physical activity, drugs. These we can intervene with. Other causes like genetic causes or endocrine causes, some very difficult to deal with. Psychological causes maybe. Polycystic ovary syndrome, BMI. Since its original description in 1935 by Stein and Leventhal, obesity has been recognized as a common feature of the polycystic ovary syndrome. In some reports, it can be up to 80%. PCOS in the most common hormonal abnormality in reproductive age women, affecting nearly 7% of this population. The reproductive feature of PCOS include increased androgen production and disordered gonadotrophin secretion, leading to menstrual irregularity, hirsutism, and infertility. The metabolic characteristics include prominent defects in insulin action and beta cell function defects that increase the risk of glucose intolerance, type 2 diabetes, and obesity. Obese women with PCOS are expected to have a high prevalence of impaired glucose intolerance and type 2 diabetes. All these metabolic factors deal with somehow the metabolic effects in PCOS. Obese women with BMI of above 30 have a 10-fold increase. Also, overweight women have about 7-fold increase in the risk of abnormal glucose tolerance compared with normal weight women with PCOS. يعني لهم higher, very much higher risk for this. Reproductive disturbances are more common in obese women regardless of the diagnosis of PCOS. Obese women are more likely to have menstrual irregularity and anovulatory infertility than normal weight women. PCOS are 5-fold more common among unselected premenopausal ovarian, overweight, or obese women compared to that of the general population. Ghrelin, this is a hormone secreted by the gastric mucosa, is produced by the gastric endocrine cells, regulates appetite and body weight. Ghrelin levels increase sharply before meals, leading to hunger and initiation of food intake, and drop after feeding, leading to suppression of appetite and satiety. So this hormone especially, it's secreted from parietal cells of gastric mucosa. It's very important in regulation of the appetite generally. So it's actually a hormone. Many other hormones, even some we don't know about them, from the gastric mucosa. This is one of the causes that we have to let the gastric mucosa as much as possible, because it's very beneficial in the both ways, in PCOS and in obesity. There is evidence that ghrelin hemostasis in PCOS may be dysregulated. Women with PCOS have less marked postprandial reduction in the level of this hormone. Lack of suppression of ghrelin following food intake may interfere with meal termination and lead to weight gain in these women. This means that ghrelin is dysregulated in PCOS. This slide may seem out of place, but it's right in the core of this, of this talk. As you can see here, this is the vitamin B absorption. Cobalamin, here is the stomach, cobalamin. This is actually studied about 50 years ago or something like that, but still many other vitamins do the same, and minerals we don't know about. Cobalamin, first of all, hydrochloric acid combines with it, so the acidity of stomach is very important for this. Also intrinsic factor, and then in the duodenum, it leaves the hyperacidity, and with the intrinsic factor, it goes to the terminal ileum. So we need 3 factors: ingested food, cobalamin, and intrinsic factor, and hydrochloric acid, and then to be digested in a very remote area, this is terminal ileum. In the same way, many other hormones and metabolites or minerals are also important. So what to do in these cases? In the surgical point of view, of course, this is the lap band. Here, lap band. There can be very extreme complications, massive complications with it. That's why it's nearly abandoned now. This is the most famous sleeve gastrectomy, with removal of all the parts of the that can lead to doing just one limb of the case in the obesity surgery cases. Just not malabsorption, it's only a restrictive way. In a restrictive way here, the parietal cells that regulate also vitamin absorption. Of course, as you know, B12, for example, it's gone. Also the hyperacidity, which is needed in many other metabolites. Okay. Here is Roux-en-Y gastric bypass also. This is very aggressive for mild obesity. Very good in super obese. Here is gastric plication. We don't remove anything, but it's a very weak modality in general. So it cannot be with many cases. Here is mini gastric bypass. Again, we have to leave part of the stomach that's not removed, but it's actually a blind loop. This part is blind loop. The water goes as the food goes as is in the red arrow here, bypassing this area. So in background, we have overweight and obese ladies with polycystic ovary who refuse that part of their body should be removed, or those who fear sleeve gastrectomy complications. These are the main target. The objective here is the idea is to combine the gastric plication, as it is a very somehow safe and modality that keeps all the gastric mucosa, with a single loop antral anastomosis to the ileum, actually in a bipartition way, like in SASI operation. For overweight or obese ladies with polycystic ovary, then observe weight loss and comorbidity. For overweight patients with BMI of 25 or obese above 30, ladies with polycystic ovary who favored bariatric procedure were subjected to this case series of new procedure as there is no resection or blind loops. This is actually here the technique. I'll describe you. Greater curve. Actually, this is greater curve was dissected and then imbricated or inwards after dissection with either harmonic scalpel or ligature. So these are the just technical details. I'll say it here. This is the normal, of course, stomach here, and then this is the part of resected in sleeve cases. This is the new procedure that we adopted. This actually the size of here of the stomach here, as in any restrictive surgery, it's not done with staples at all. It's only done with laparoscopic sutures. 2 rows, one of them is interrupted, and the other is continuous. To have enfolding and imbrication of the stomach with reduction of the internal size, keeping in mind the whole gastric mucosa is intact, and this is very important. As you see here, the gastric outlet, there is 2 ways. Either the normal way, we don't come near to it, and this part. Here's the gastrogenous part in a bipartition way, about 2 meters to 3 meters above, beyond the gastrogenous, beyond the digital flexure. If you want to do more description, this is how to be done. It's just after gastric greater curve dissection, just do laparoscopic suture in 4 in 1 pattern, so that we have 2 here, 2 here, and then suture it, and then the second row continues. And this is the most important. Here is the plicated stomach, antrum. This is a gastrogenostomy bipartition way. Here is small video to demonstrate that I do also upper GIs. Here is the laparoscopic view with the scope coming here. Okay. Meanwhile, at the same time, I do this. My assistant was finishing the laparoscopic suture. Here is the antrum. I'm coming backwards with the gastroscope. This is the everted mucosa, imbricated mucosa. It will be here, of course, I inject air to have some sort of volume here, some sort of view. Actually here, this is the gas mucosa, all of it is intact and fully functions, not a blind loop. fully function here gives a lot of no need for post-operative vitamins or minerals. Results, we can say this in next slide. Just for the preoperative weight, about 100, and after 2 years, it's about 70. It can be in much higher BMIs, but it's actually what we stress here. It's not the BMI as it's the adolescent or you can say teenager group. This is post-operative in BMI after 24 months. Until now, there is no weight regain, as there is two-way for the gastric outlet. What are the possible mechanisms here? Any bariatric surgery you can do. It's either restrictive or malabsorptive. These are the two main limbs for any bariatric surgery. Okay. Others we don't know about it, but we can deal with some. Microbiome changes. It's still an idea. We don't know about it. Posterior gut hormone changes. This is very important, as GLP-1 and PYY especially. Bile acids concentration shift, it's evident. What actually happens at the end is gut-brain axis shift leading to new set point. البيشنت بيختلف. الset point بتاعه كله بيختلف. Gut-brain axis shift, this is the most important thing. Surprising results بالنسبة لنا اللي هي regain of regular menstruation after 3 and 4 months. واحدة مثلا كانت 14 سنة 15 سنة أمينورية، بعد مرة واحدة بقت خلاص الشكل بتاعها اتحسن، body mass index بتاعها اتحسن جدا، وريجين normal without any other drugs menstruation after 3 and 4 months. Ultrasound reduction of size and number of ovarian cysts. This is proven. Some got pregnant immediately afterwards. This can be a problem for us because it's what did he do? But some thanks God there was a husband yet, mostly yet. Conclusion, we can say that physiologic operations with no resection or blind loops, or gastric balloon application and SAPI. SAPI, this is the new procedure for us. Generally less vitamins and minerals loss, more smooth pregnancy even. And even afterwards, it's much more better or easier to get pregnant and much easier to perceive this pregnancy. Non-physiologic procedures as sleeve gastrectomy, mini gastric bypass, Roux-en-Y gastric bypass, generally more vitamins and mineral loss, more difficult pregnancy, and waiting for much more for this to happen, you can say. Thank you.
Thank you, Dr. Muhammad, for this interesting presentation. The next talk will be presented from Dr. Muhammad Haggag, female extraaxial varicose veins.
Thank you, Chairperson. It's my pleasure being among you. I am Muhammad Haggag, consultant of vascular surgery in Shams University. Today's topic, I will not go in details in vascular surgery point of view, but I want to emphasize how what is the way to refer these female patients in a proper way. Pelvic congestion syndrome was the old name, and now it's called pelvic venous disease, which is a specific disease with a specific definition and have an objective tools and way of management. It's like chronic pelvic pain that affect women in childbearing period, and it classifies according to Milka-Griner into 3 types. The most common type is type 3, where most of females complain of dysmenorrhea, dyspareunia, and pain in leg during menses. This is really important because most of these female, if they have local gynecological cause, treatment of pelvic disorder is through treatment of the primary cause. If this female don't have any pathology, so they should be referred to vascular surgery department because there might be probably type 1 or type 2. Type 1 is like varicose veins, simple valvular disease, or simple venous reflux. Type 2 is like a reflux secondary to obstruction. A most common type is May-Turner and Nutcracker syndrome. Most of obstructive pathology should be different between whether it's significant or insignificant May-Turner or Nutcracker. Why same venous pathology causes different symptoms in cohort patients, and why same symptoms in cohort group were of different venous pathology? This is because Professor Mark Meisner show in this slide that female have 4 venous reservoir: zone 1, left renal vein; zone 2, gonadal vessels and internal iliac veins; zone 3, pelvic and extrapelvic veins; zone 4, lower limb veins. All these 4 zones are connected through each other. So in female, all these veins considered as one vein, unlike in male. So if the patient start to suffer from venous hypertension in renal vein, like in Nutcracker, pressure could be transmitted up to lower limb and etc. As we all know, hypogastric veins are interconnected through each other through several plexus. These tributaries is really important, especially the parietal tributaries between iliolumbar lateral sacral and obturator vein. We'll discuss it shortly. For example, if a patient have a reflux in left ovarian vein, the pressure should be transmitted directly to pelvic reservoir. If this pressure transverse through the pelvic floor into lower limb, so it's called compensated pelvic state. So 2 patients have left gonadal vein reflux. One could have left loin pain and the other could have lower leg pain according to pelvic leak points. Another example of patients who have non-thrombotic left renal vein occlusion, the old name Nutcracker syndrome, could have pressure transmitted directly through left ovarian vein into pelvic floor and even into lower limb. Here is the tool that we always use. It's considered of 3 components: symptom, varices, and pathophysiology. Symptom started from renal up to venous claudication. Varices start from loin and hilar varices up to lower limb varices. And lastly, anatomy. We have 6 pelvic leak points, which are really important in understanding the extraaxial varicose veins: gluteal, obturator, perineal, inguinal, and clitoral point. Perineal is the most common, then followed by inguinal. Inguinal and obturator seen in anterior view, while perineal and gluteal seen in posterior view, this through the venographic finding under theater. Gluteal and obturator points seen inside true pelvis, while perineal and inguinal outside. And the last one is how we report these patients. For example, this means that patient have a loin symptom with hilar varices and left renal vein obstruction, non-thrombotic. So this means is a case of Nutcracker. This is how we report it for a standard of venous reporting. We have a solid guidelines in vascular surgery and how we manage these females. And there is contraindication to treat females who have pelvic symptoms and have local gynecological cause. So if some patients came to my clinic and suffer from pelvic varicosis and she have endometriosis or adenomyosis, I don't treat them, and they should be treated first by gynecological consultants. During menses, we also ask about the pain. If the pain is seen inside the thigh, it's referred from obturator vein. If the pain during menses is in anterior thigh, it's mostly due to inguinal vein. If the pain or the varices in the posterior thigh, it's mostly due to gluteal varices. Here's some cases of gluteal and sciatic varices. This is considered in vascular surgery as atypical varicosities because its distribution is away from saphenous. Here is some varicosities being, if someone sees that varicosities in anterior aspect is more than in inner aspect, so it's come through anterior accessory saphenous, mostly of pelvic origin. Treatment of this female should be directed toward pelvic, then lower limb, not lower limb. Here's some pictures of left gonadal vein before and after embolization. Picture A show left gonadal vein reflux. Picture B seeing the siphoning effect of hypogastric veins in draining veins and blood from left ovarian vein. And C and D is after embolization. We use a lot of embolic agents. Some of them are metals and some of them are fluid, according to the number of veins and tributaries seen in venographic finding. Here's some picture of left gonadal vein before and after. Here's after. Picture F is visualizing some coils. Here's some picture of right gonadal vein reflux. Here after coiling. If you found picture F, there is a lot of channels, so metal here will not be enough, so we use another fluid embolic agents. Here's some picture of pelvic leak points. The first picture shows the P point, which contributes to medial thigh varices. So if this female treatment of them directed toward lower limb only, they will suffer of recurrent varicose veins. And if this female have a pelvic symptoms and we treat lower limb, they will suffer from pelvic decompensation and increase of pain after treatment of lower limb varices. Here's some obturator vein reflux. Obturator vein is connected through lower limb veins. And the last picture is gluteal vein reflux that contributes to sciatic varicosities. Here's some pictures. And onyx, we use onyx or glubron or histoacryl or etoxysclerol as a liquid embolic, and we use coiled, whether pushable or detachable coil, as metals. Here we can't use, for example, a metallic coil because a lot of gonadal tributaries, so we prefer to use fluid embolic. Here's some treatment of pelvic skip points where we embolize obturator vein because it's refluxing vein. We also, during treatment of lower limb, we should exclude in all female who have age from 30 to 50, we should exclude pelvic-derived lower limb varicosities. Like there is a difference between saphenofemoral junction in pre-terminal and terminal valves. They classified according to Eric Mendoza into type A, B, and C. A is an ascending type. B is both cranially directed and ascending. C is a caudal directed or pelvic derived lower limb varicosities. Here the castor is inside the left gonadal vein, and if we see the left gonadal vein, the blood is draining into the hypogastric vein back to common iliac, then to the cava, and here is the picture that show right gonadal vein. Most of veins are connected through each other. This picture is unique in female, not in male at all. Why this female should be referred for vascular surgery department? Because we always give a wide range of management, from simple medical treatment up to gonadal vein or renal vein transpositioning. Here a picture where the IVC, inferior vena cava, and here is the right gonadal vein, and here is the right renal and the left. This patient have a narrow aortomesenteric angle called nutcracker syndrome, so I did renal vein transpositioning into a more distal segment of IVC to relieve severe form of pelvic congestion syndrome type 2 secondary to renal vein compression. Here's some picture before and after. If you see here, there is pelvic varicosis reaching to vagina and vulva. Thank you.
Thank you for this great presentation. We have one question, if you can allow. دكتور محمد سؤال مني معلش. يعني I have read a lot about the pelvic congestion syndrome and the role of abnormal vasculature in that. Are there a certain surgeries or interventions you are doing for the patients, how we can identify that this patient, this is a cause of pain, this is a vascular origin,
Yes.
and how we can intervene?
Yes.
When to refer to you as a vascular surgeon a case of chronic pelvic pain? In 1 minute, please.
Okay. This is a key question, sir. If a patient came for me as a primary surgeon and she have an endometriosis or fibroid, I don't treat them. I should send it for a gynecologist who treat them, because treatment of the cause is treatment of pelvic symptoms. If the patient referred to me from your department, mostly you excluded all causes of gynecological cause, so I do transvaginal duplex. If the duplex show reflux in pelvic vessels and diameter more than 5 millimeter, treatment and embolization of these veins will relieve symptoms. Thank you.
Thank you. Here we go to the final presentation. Dr. Munir Mustafa, one of the stars of hysteroscopy in Egypt. We can expect an exciting talk. He'll talk about hysteroscopic tackling of deep myomas.
مساء الخير. Good evening, everyone. Thank you, panelists and attendees. I think I'll go directly to the topic because of the time.
Yes.
Submucous leiomyomas represent 5 to 10 of all uterine leiomyomas, a disease which caused in USA, for example, more than breast, ovarian, and colon cancer. Protruding into the uterine cavity, submucous fibroids may induce excessive bleeding, pain, and also related to delayed fertility. The hysteroscopic myomectomy is the first-line invasive, minimally invasive surgery and the conservative treatment for those who need fertility preserving. To facilitate the grading of the myoma and types of myoma during hysteroscopic myomectomy, we have the FIGO classification. This is the simplest available classification. There are other classifications, but we won't use them. We have 3 types of submucous fibroids. FIGO 0, where the whole myoma is intracavitary with a pedicle. Type 1, in which most of the myoma, more than half of the myoma, is intracavitary with the largest diameter in the cavity and less than half the myoma inside the myometrium. And type 2, or grade 2, where more than 50 of the myoma is inside the myometrium with the largest diameter inside the myometrium. There's another one, FIGO 3, which is not a real submucous fibroid. 100% of the fibroid is intramural, but it's related, it's touching or very near from the endometrium. Okay. But for FIGO 3, we have evidence that they are associated with a lower implantation rate, cumulative birth rate, and live birth rate. And we also have evidence that hysteroscopic myomectomy of FIGO 3 myomas is a safe and feasible approach. In this lecture, we will see how to manipulate to remove the deep myomas, FIGO 2 and FIGO 3. But first, we have to check what is the simple resection technique. Okay, and this is FIGO 1 myoma. This is the simple resection technique. You go with the resectoscope, you start resecting backward to the front. Okay. For FIGO 0, you will have the full resection of the myoma intracavitary. For FIGO 1, the small part of the intramural myoma will start to bulge inside the cavity easily. Okay. But this technique, you can't use it for deeper myomas because this will lead to significant myometrium and endometrial damage. For example, to remove this FIGO2 myoma, you have to destroy this green area of myometrium. For FIGO3, of course, it's much more deeper and more myometrial damage. We'll see a lot of videos from many surgeons where they just go with their sectoscope for FIGO3 and they remove the whole thing of myometrium, including the fibroid. So how to do this? We have to do something called transpseudocapsular cold inoculation. We have to do mechanical dislodging of the myoma outside of the myometrium and push it towards the cavity using the mechanical dissection, the hydrostatic effect of the distension fluid and uterine contractions. During this procedure, we degrade the myoma from FIGO3 to FIGO2 to FIGO1 up to FIGO0. We are ensuring a complete removal of the myoma with minimal damage of the myometrium. This minimizes the risk of perforation, bleeding, and fluid intravasation. It also has the best healing outcomes with less adhesions. You see, this is the FIGO2 myoma. We go through the capsule, pseudocapsule around the myoma, pushing it inside the cavity, then removing it like FIGO0 or FIGO1. Okay. The hole where the myoma was there, the defect in the myometrium is not closed by healing. It's closed by uterine remodeling. The uterine contraction and the fibers move from their places to cover the area in which the myoma was there. That's why the minimal damage to the myometrium improves the outcome of the healing. Okay. We need something more in the preparation before doing this kind of surgery. We have to have mapping. We have sometimes for FIGO0 or FIGO1 fibroids, I can do the ultrasound and then I do the resection. But for deeper myomas, I have to have an expert ultrasound, documentation and imaging, measurements, especially the residual myometrium and the size of the myoma, and grading. It's very important for ultrasonographers to write the grade of the FIGO grade of the myoma for me. I counsel the patient for inaccurate imaging, which is not rare, and double sessions because I would be ready to stop anytime during the operation. Also, you should have an intraoperative ultrasound machine with abdominal and vaginal probes. This is the setup where I work such operations. The technique starts mechanical, usually by scissors. This is the FIGO2, this is FIGO3. At the beginning, the cavity was empty. She had a history, this patient had a history of diagnostic hysteroscopy, and they said the myoma is not near the cavity. Now you are cutting a linear incision, longitudinal incision. This is myometrium, thin layer of myometrium, behind which you'll find the myoma. This is a 3 centimeter myoma, FIGO3. This is a 3.5 FIGO2 myoma. I know it's a bit difficult to watch two videos, but I have no time. Once you cut the pseudocapsule here, the myoma starts to protrude inside the cavity. The other way here in the FIGO3 will take more time. Just we cut one single line longitudinal, then we try to inoculate the myoma from sides and from below. That's why it's called tackling. We are trying to dislodge the myoma. I'm not trying to cut the myoma. We won't start resection now. You have to move the myoma at least for FIGO1. We'll have here some special management for the fluid and operative preparations. I'll show you later. The operation can take a long time. Now see, this is the pseudocapsule, and we are pushing with the scissor. We are pushing the myoma, rolling it inside the cavity. Here we're reaching like FIGO1. It became FIGO1, so we can start the resection. This is becoming FIGO2 to 1. Meanwhile, you have uterine contractions pushing the myoma inside the cavity. Now, when we start a section, this is the normal myometrium. We don't have to go through all the myoma to resect it. It's always better to inoculate the myoma, leave like a rim of the myoma, and then you can get it by an ovum forceps or another tool we'll see now. Okay. We have always to make sure where is the pseudocapsule, where is the fibroid, and where is the normal myometrium. This one, we finished. This became like an empty myoma. We are trying to push it, make it a myoma degraded. Now, when we use the evacuation with the open forceps, you will see the pseudocapsule with no traces of resection. Okay. This is after evacuation. This is the pseudocapsule of the myoma. We don't have any injury there. The other one will take some time, but the same idea. You have to resect until you have like an empty half of the myoma. Then by the forceps under ultrasound guide, this is the pseudocapsule with no traces of injury. Okay. Sometimes for small myomas, this is very common. We have pure mechanical inoculation. You just open the myometrium, you get the myoma out, you push it into the cavity with complete separation. There is some evidence in literature that it's safe to make myomectomy without extraction, especially if you are doing an office procedure. You can get out the myoma, put it in the cavity, and leave it if it's an office procedure. I don't do this really, but there is some evidence that this is safe. Of course, tackling with the 5 French scissor is very difficult and very risky for the scissor first, and for the patient, because we have if the scissor broke inside the operation, sometimes it breaks inside the cavity, sometimes you couldn't complete the operation. There are now some bigger tools to perform this, but they're not available everywhere, so I didn't spend a lot of time showing them. Now, we are cutting all around the myoma, and the last we are pushing the myoma inside the cavity. Using now, there are some tools like myoma screw and shavers, and this, we'll see them. Okay. This is a 1.5 Figo 3 fibroid, 1.5 centimeter. That's it. There are other tools we can use. They are not commonly used and they're not available in Egypt. The cold loops of Mazzoni. These loops work on the resectoscope, but they don't connect to the electricity. They are thick metallic loops where you can push and resect with them. They are somehow more stronger than the scissors and I think cheaper. Also, for the oven forceps we use this one, this regular one. We have a problem with it. When we open it inside the uterus, the cervix blocks its complete opening. So there's something like Corson myoma forceps and Lean's myoma forceps. They open only from the distal end, like the crocodile. And they have more grasping teeth than the normal oven forceps. This is the new generation of instruments we use in this technique, like the shavers, MyoSure and Ductil. They are like the morcellators of laparoscopy. Also, their telescopes enable us to insert larger devices like 3 millimeter scissors, graspers, myoma screws, and bipolar electrodes. There's here important thing about the safety with fluids, because these operations, they are both lengthy and we go deep into the myometrium, so there is a good amount of intravasation. The maximum fluid management measures should be used and are mandatory. Monitoring of the fluid inflow, amount of fluid, rate, outflow, pressure, and deficit with plotting on the chart and time is very important. Pauses of 10 minutes, this is not very common in literature, that if you see that you have a long hysteroscopic operation, you stop for 10 minutes. You cease the operation, you off the gloves, you turn off the devices. During this 10 minutes, maybe you give diuretics, you insert intra-urinary catheter, you measure the amount of fluid out, and you subtract this from the deficit. From 65 to 80% of the deficit can be decreased during this 10 minutes. In this kind of operation, this will give you another benefit that you can make some uterine massage, give methergine, and more myoma will be pushed inside the cavity. Termination of the procedure should be considered all time. I am not waiting to complete the operation, I am waiting to stop the operation anytime. Safe better than sorry, and always you have your team ready. This may only be the beginning. From less than 1 year, we had the first video of robotic hysteroscopic myomectomy using the laser. This was done in USA under very special tests. So it's not available to watch it again or not available for sales, and it's not yet available. This is a guiding probe, manipulating probe. This is a laser probe. And the myoma is here rolled up by the probe and cut with the Nd:YAG laser. Thank you.
Thank you, Dr. Munir. The platform open for questions, please.
Thank you for this excellent lecture. I have two little questions for you.
Yes.
The first, during patient selection, do you have a size limit of the myoma? I recognize you are talking about type 3, FIGO type 3 myomas, whatever the size, or is there a size limit? The second question is, after removing the myoma, do you need to have a second look hysteroscopy after some while, or you don't do this? Thank you.
Thank you. I like the questions. The first one, we don't have like a reference which tells you what is safe or what's not safe, because this is recently a new technique to approach FIGO 3 myomas, and there isn't like a lot of studies about the outcome, but there is a consensus in the hysteroscopic community surgeons that for FIGO 3, you operate up to 4 centimeter, which is very big, with residual myometrium behind the myoma more than 5 millimeter. Okay. Sometimes we're stuck in bigger patients, in bigger myomas, like you go for myoma, you think it's type 1, then you go inside, you just open a small slit, you find it type 3, then the myoma start coming out. So it always depends on if you have the facility to make another session, okay, you can operate larger myomas. But for planning for a single session, it's 4 centimeter with a residual myometrium more than 5 millimeter. For the second question, usually we don't do second look, but for the ultrasound, yes, it has to be done regularly until you have the full thickness of the myometrium resolved. For GnRH, it's valuable if you have the time to do it, but if this very large myoma or multiple myomas, but for just single myoma, which is type 1 or type 2, it won't make much difference. For cytotic, no, it's now not recommended to give cytotic, because for the normal procedures, cytotic just makes pain for the patient preoperative, and you don't need it for regular insertion of the hysteroscope. If you will dilate, there is some literature that it makes the cervix softer and so more liable for perforation. So usually we don't give this.
Thank you very much, and let's close the session now. Have a lovely evening all.